Okay. My patient is an 84-year-old man with a 9-year history of Parkinson's disease. He is retired and he lives at home with his wife, who is also retired. She is able to provide him with limited assistance due to her history of cardiac disease. Um, and they have recently hired a home health aide to provide 4 hours of assistance per day. They live in an apartment that has no steps to enter. And the patient has the following durable medical equipment at home: a straight cane, a tripod rollator, a shower chair, a commode with 2 grab bars installed in the bathroom. And regarding the knowledge of pathophysiology and how that will guide my examination and evaluation, knowledge of the pathophysiology of Parkinson's disease will guide the examination and evaluation by informing the line of inquiry. Knowing that Parkinson's patients often have issues related to initiation of movement, rigidity, tremors, slowness of movement, decreased speed, and postural impairments, I'll be sure to address these issues and any that relate to them when reviewing the patient. I'll be sure to look for medications in the chart that people with this condition regularly are prescribed, and keep in mind how they may affect patient capacities. The knowledge that Parkinson's is progressive, and if levodopa therapy had been initiated several years ago, that this condition will only worsen, especially if the patient has already had extensive PT. That'll make compensatory rather than restorative strategies more likely, although restoration of whatever potential is possible will still be the first priority. Regarding significant past medical history, the patient has recently experienced a deterioration in balance, gait, endurance, and strength. He was hospitalized for 12 days to monitor the deterioration and adjust medications accordingly. He was then transferred to inpatient facility for 2 weeks and then had home health therapy for 4 weeks, and now he's been referred to outpatient physical therapy, which is the setting that I will be seeing him in. His general health status is fair. Prior to his last hospitalization, the patient was able to ambulate independently with a straight cane. His current level of function is that he uses that straight cane at home for short distances, and then he ambulates outside with a rollator and contact guard assistance, secondary to his imbalance and increased fall risk. The patient does report an average of about 3 falls per month. He uses a motorized scooter when he's traveling further than about 4 blocks distance. The patient also reports some difficulty with rolling in bed in both directions and transferring from supine to sit and sit to stand, and also with donning and doffing clothes and eating. The current medications, their purpose and potential side effects: the patient is taking Sinemet, which is a carbidopa-levodopa combination. Those, of course, are levodopa is a dopamine precursor, and carbidopa helps it cross the blood-brain barrier without being metabolized. So more of it can get to the brain, to the CNS, and lower percentages of levodopa can be used to decrease the risk of side effects with the overall goal to increase dopamine levels in the CNS, of course. Side effects from Sinemet include dizziness, lightheadedness, nausea, vomiting, headache, loss of appetite, trouble sleeping, and unusual dreams. The patient is also taking Mirapex, which is a dopamine agonist, which increases the dopamine effects. It also causes dizziness, lightheadedness, nausea, vomiting, headache, loss of appetite, trouble sleeping, and constipation. The patient is also taking Lexapro, otherwise known as escitalopram, which is a selective serotonin reuptake inhibitor, antidepressant, also for anti-anxiety. But the patient does suffer from depression, so he is taking the antidepressant, presumably for that condition. Side effects of this drug include headache, nausea, vomiting, diarrhea, dry mouth, increased sweating, feeling nervous, restless, fatigued, sleepy, or having trouble sleeping. The patient is also taking an iron supplement, possibly for anemia or iron deficiency. That was not stated, and his side effects from iron can include stomach pain, nausea, vomiting, and constipation, But curiously, iron can also cause Parkinson's or exacerbate Parkinson's symptoms. I have a note for the patient to inquire about this, to ask his primary care physician about this, and to clear the iron supplement that he's taking if it was not prescribed by the MD. The patient is also taking Zocor, also known as simvastatin, which is a statin, of course, for cholesterol and triglyceride levels. The side effects for this drug are heartburn, gas, bloating, stomach pain, indigestion, nausea, constipation, diarrhea, headache, joint pain, muscle pain, skin rash, sleep problems, mostly insomnia, mild memory problems or confusion, and stuffy nose, sneezing, and sore throat. These medications, especially dizziness, lightheadedness, nausea, vomiting, sleep trouble, and headache, will all tend to make therapy more difficult and may make the patient less functional, less compliant, and certainly less energetic in therapy sessions. Other medical concerns and how they're being managed. The patient reports that he has a history of prostate cancer currently, and it's unclear how it is being managed, if he is currently undergoing treatment for it or if he's already completed treatment. But he has an order in to ask his physician about this, since he was not sure himself. His left upper extremity, he has adhesive capsulitis, and this is status from post-trauma from a motor vehicle accident. The patient doesn't recall how this has been managed, but certainly it will be included in my evaluation, examination, and treatment of him. The patient also reports depression. It's being pharmacologically treated. However, I would like the patient to ask about forms of psychotherapy that could also be used besides just medications. The patient had a right total knee arthroplasty 8 years ago. He also had a left total knee arthroplasty 4 years ago and a left total hip arthroplasty 3 years ago. There's no information in the chart concerning those, but they will be assessed with range of motion and strength, of course. During the examination, results of diagnostic tests, examination tools, and other objective descriptive measurements are as follows. I wanted to start with range of motion because that is often decreased in patient population who have Parkinson's, and wanted to see how certain motion deficits might be contributing to his history of falls and his decreased mobility. I also wanted to assess strength with MMTs, sensation, and coordination, dermatomes, pain, deep tendon reflexes, and balance using functional reach assessment, the timed up and go, and also the Tenetti POMA, since the patient has a high fall risk. Regarding the results of the active range of motion examination for the cervical and for the spine. Cervical spine range of motion was 0 to 30 degrees, and flexion, extension was 0 to 18. Those are both decreased. Right rotation was 0 to 52, normal. Left rotation 0 to 38, slightly decreased. Side bend to the right was 0 to 10 degrees. Side bend to the left 0 to 30, so decreased to the right. Lumbar flexion, he had 0 to 15 degrees, and extension 0 to 5 degrees. Both of those decreased. Right rotation 6 degrees, left rotation 4 degrees, and those are both slightly diminished. Right side bend 10 degrees, left side bend 20, a little diminished on the right there. His hip range of motion, straight leg raise, 0 to 35 degrees on the right, 0 to 25 on the left, both of those quite diminished. That's a major limitation. Hip flexion 0 to 100 degrees on the right, 5 to 90 on the left, so a little decreased on the left there. Extension, he lacks, he was 0 degrees of extension on the right and lacks 5 degrees on the left, so his left hip is definitely much more limited. Abduction 0 to 20 on the right, 0 to 10 on the left again, more decreased range of motion in the left hip. Ankle plantar flexion 0 to 10 degrees on both sides bilaterally, that's diminished Ankle dorsiflexion 0 to 5 degrees bilaterally, also diminished. Shoulder flexion 0 to 110 degrees on the right, 0 to 70 on the left, diminished. Extension was 20 degrees on both sides, normal. Abduction 0 to 120 on the right, a little diminished, and 0 to 60 on the left, quite diminished there. Internal rotation 0 to 18 on the right, 0 to 10 on the left, both diminished. External 0 to 40 on the right, 0 to 36 on the left, diminished there as well. His sensory integrity, he had impaired response to light touch on bilateral plantar surfaces of his feet, no response to light touch during 4 out of 10 trials on the right foot, and 6 out of 10 on the left, so slightly more decreased on the left. He also had impaired ability to discriminate between sharp and dull sensations on both feet, plantar surfaces, in 5 out of 10 trials. And he also had proprioceptive awareness on great toe bilaterally. He was incorrect on 4 out of 10 trials on the right and 6 out of 10 on the left, but he did have intact proprioceptive awareness at the ankles bilaterally. His strength for his hips, bilateral hips, where flexion was 4 out of 5, extension 3 out of 5, so only full range of motion against gravity. That's a bit diminished there. Definitely will be addressed in the plan of care. Abduction and adduction, both 4 out of 5 bilaterally. His knee was a 4 plus out of 5 bilaterally for flexion and a 5 out of 5 for extension, so good extension strength, a little limited in flexion. Plantar flexion, he had a 3 plus out of 5 on the right and a 4 plus out of 5 on the left, a little diminished there. Dorsiflexion 3 plus out of 5 on the right and 4 plus out of 5 on the left, a little more diminished on the right there. Shoulder flexion was a 4 minus out of 5 on the right and a 3 out of 5 on the left. Extension a 4 out of 5 on the right, 3 out of 5 on the left. Abduction 3 plus out of 5 on the right, 3 minus out of 5 on the left. And internal rotation and external rotation were both 4 out of 5 on the right and both 3 out of 5 on the left. So significantly decreased on the left side throughout, more than the right. His deep tendon reflexes, he had a 1 plus, so diminished but present bilaterally with triceps, and then no response for both bilateral biceps, hamstrings, patellar, and ankle responses. So diminished DTRs there. In coordination testing, he scored with his right side a 4 out of 5 with finger to nose and 3 out of 5 on the left. Finger to therapist finger was 3 out of 3 for both right, 3 out of 5 for both right and left. Pronation supination was a 4 out of 5 for both right and left. Heel to shin was a 4 out of 5 on the right, 3 out of 5 on the left, and foot tapping was 4 out of 4 bilaterally. The patient reported 3 out of 10 left shoulder pain at rest and 9 out of 10 with activity. The patient scored a 4 inches on the functional reach assessment, which indicated a very high risk for falls. He also took 26 seconds to complete the timed up and go test, indicating also a high risk for falls, and his score is 12 out of 28 on the Tenetti performance-oriented movement assessment, again indicating a high risk for falls. In discussing his findings, he had decreased range of motion, especially in hip flexion and hip extension, weakness general, but especially hip extension. His balance is diminished, and the fact that he scored as a high risk for falls on all of his balance outcome measures matches that he has about 3 falls a month, and indicates that he should probably keep using the roller outside for increased distances. In terms of interventions, the 2 interventions that I chose were PNF stretching with contract relax for his tight hamstrings, because his hip extension was so limited, and that was likely contributing to his posture. And he had the classic forward kyphotic and posterior pelvic tilt posture for a Parkinson's patient, and so PNF stretching for tight hamstrings should help alleviate some of that tightness and get him to a place where he can align his body with gravity a little better, and also hopefully take bigger steps when he's walking, because he also had the typical shuffling gait. Hip bridges were also prescribed for his hip extensor weakness, and also to increase bed mobility. and sit-to-stand in ambulation. Um, in terms of the evaluation and prognosis, talking about the link between pathophysiology and clinical presentation using the disablement model, his impairments, his direct impairments, were decreased dopamine, decreased strength, decreased range of motion, decreased sensation, and increased pain. Functional limitations were a decreased ability to walk, balance, transfer, and perform bed mobility, and participation restrictions were inability to walk community distances for shopping, doctor's appointments, and then, of course, his decreased strength and coordination decreases ability to perform ADLs and increases difficulty with participation in community events and recreation. The most important activity and participation limitations for this person based on my history were his balance. Based on his history of falls and his risk for injury due to falls, and also his slow gait speed, bed mobility, and transfers, these were important as well. However, a fall at his age, a bad fall, could, as Dr. Thomas likes to say, take him out quick, fast, and in a hurry. A broken hip for somebody in his condition would likely increase his risk for other comorbidities. The key impairments that I think have the strongest impact on activity and participation are range of motion and weakness. In terms of how amenable to change these impairments are to physical therapy, well, weakness and range of motion can be addressed well through the interventions provided, and of course the full plan of care would address these in greater depth and breadth. Regarding whether they would be addressing the functional or impairment level or both, the interventions would be directed at both the function and impairment levels since they are intimately related in this patient. Deficits in strength, range of motion lead to deficits in balance, bed mobility, transfers, and gait, of course. But each must be addressed without assumption that improvement in one area will necessarily lead to improvement in others. So strength needs to be addressed, however, he needs functional training for things like bed mobility, transfers, and gait. In terms of what degree my interventions will be aimed at restoration versus compensation, the interventions at first will focus on restoration under the assumption that the patient has diminished capacity that could be improved through traditional physical therapy exercises like stretching and strengthening and coordination training. However, the patient already avails himself of several assistive devices, and it is likely that his dependence on them will only increase. Thus, compensatory strategies will fill in the gaps that restorative ones are not able to fill. However, of course, restoration would be the first priority, if possible. In terms of impairments or activity limitations that this person is at high risk for developing without any interventions, based on the patient's living situation, it's possible that he could rapidly decline given his need for assistance in bed mobility and transfers if his wife or their hired aide were not available or no longer available to assist him. Issues like pressure ulcers could develop if the patient were no longer able to get out of bed. Toileting, bathing, shopping, visiting the doctor, other things requiring mobility, transfers, and balance could also become impossible without the assistance he currently has. Additionally, as mentioned, the patient has a high risk for fall and fracture based on his impaired balance, coordination, strength, and range of motion. The potential for this person to benefit from physical therapy intervention is fair. Certain areas have better potential than others. Increases in range of motion and some strength should be possible unless the patient has already been treated regularly and thoroughly by a PT who has addressed these deficits. Assuming this is not the case, the patient will make gains in strength, range of motion, and endurance under my plan of care. He may or may not improve coordination, balance, and initiation as his diagnosis was 9 years prior, and recovery is not common once levodopa has been used regularly for years. Which we are not sure of. That's a question for the primary care physician. This reckoning is supported by his past history of illness and by literature showing the potential of Everly to make gains in strength and range of motion. He has potential to improve if he has not already maxed out that potential through therapeutic exercise and working with a good physical therapist. Factors that contribute to my estimate of the rehab potential. Well, the patient's diagnosis of Parkinson's 9 years prior is a negative prognostic factor regarding rehabilitation potential, as is his age of 84 years. his past history of frequent falls, and also his prior surgeries, but there is likely untapped potential for gains to be made in strength and range of motion. The amount of functional change that I would expect to see in a week, a month, etc. with physical therapy intervention, changes in a week would be very minimal. Within a month, there should be noticeable changes in strength and range of motion, not large, but noticeable above the minimal detectable change. And then within several months, larger increases in flexibility would be noted. And beyond 6 to 8 weeks, true changes in strength increases would be seen. They wouldn't be large, but they'd be significant. This person, would they benefit from referral to other specialists at this time, and for what? Yes, based on the patient's history of falls, it's a good idea for the patient to check in with his neurologist. Again, as mentioned, his use of iron should be approved by a doctor, as it can cause exacerbation of Parkinson-like symptoms, and it must be clear to see if he has to keep taking it. Other members of the team, the rehabilitation for this team, would likely include an MD, probably and possibly a neurologist, an OT, a social worker, and eventually a speech-language pathologist as speech and swallowing issues arise. Potential areas of overlap between the PT and other team members. Obviously, PT and OT may overlap in dealing with things like upper limb coordination and function, and the physical capacity department, strength, coordination, balance, and transfers, which are needed to complete things like ADLs, which is the OT's department, and of course other functional things, which are the PT's department, like transfers. In terms of goal setting, key activity and participation limitations that are of main concern: bed mobility, transfers, gait, and balance are all affected, but again, fall risk, gait and balance combination here is the most concerning. The goals that the patient and the family have are to decrease falls and increase ability to ambulate. How realistic are these goals, and can they be modified? Well, these goals may be realistic, but they'll be broken down into smaller segments so that they're easier to accomplish, starting with increasing range of motion and strength. That will be more manageable than trying to tackle these goals as one large chunk. Breaking them apart that way will make them much easier to accomplish. They'll also provide the foundation to increase the function and work and they'll help work toward the patient goals. They will also establish measurable time limited and functional goals at the activity and participation levels. Short-term goals for this patient include the following. In 2 weeks, the patient will demonstrate supine bridge with 3-second hold at the top in 3 out of 3 trials for increased strength, range of motion, and ability to achieve neutral pelvis and ambulation. That will be one of his exercises. In 2 weeks, the patient will perform supine hamstring stretch daily with a belt for increased ability to achieve neutral pelvis and ambulation and sitting. In terms of long-term goals, in 6 weeks, the patient will increase hip extensor strength from 3 out of 5 to 4 out of 5 by performing bridges and prone hip extension for increased gait speed and decreased fall risk. In 6 weeks, the patient will increase hamstring length by 15 degrees bilaterally for increased ability to stand with neutral spine, increased mobility, and decreased fall risk due to improved balance from better center of gravity within base of support. The amount of therapy that's recommended and the setting. The therapy will take place in the outpatient clinic, and it's recommended to have 3 times per week for 8 weeks to start. Interventions that are recommended to address the physical therapy goals are patient education, first and foremost, strengthening of hip extension, flexion, abduction, adduction, knee flexion, plantar flexion and dorsiflexion, shoulder flexion extension, and abduction and adduction, stretching, soft tissue mobilization, diaphragmatic breathing, modalities including hot pack and neuromuscular electrical stimulation, and functional training in bed mobility, transfers, balance, and gait. These interventions will address deficits addressed in patient goals relating to gait, mobility, transfers, balance, and participation. These specific interventions were chosen to address weakness, deficits in range of motion, deficits in balance, dependence in transfers, and deficits in gait. Regarding education, education of the patient and the patient's wife and the hired aide will take place regularly throughout treatment. The patient will be educated directly about the reason for each intervention and the desired outcomes. The The patient's wife will be educated concurrently so that she can work to increase compliance at home and assist with the home exercise program as needed. The home aide will also be educated as to the patient's plan of care so that the aide can also help with compliance and provide support where most appropriate given the patient's situation at home. Activities that are recommended, including the duration and for how long. He will start with 3 sets of 6 reps of the supine bridge with 3-second hold daily, and this will be indefinite. It's a really good maintenance exercise and strengthening too. He'll perform prone donkey kicks, 3 sets of 10, 3 times a week for 8 weeks. Heel and toe raises, 3 sets of 10 each indefinitely. Mini squats, 3 sets of 3 sets of 10 for 8 weeks, and then he'll transition to sit to stands, 3 sets of 10 after that 8 week if he has progressed sufficiently. He'll perform hamstring stretches, 3 sets of 30-second hold each day indefinitely as well. Since he's prone to develop a contracture here if he's not careful, he may already have one on the left side. Wall push-ups, 3 sets of 10 for 6 weeks, and then he'll progress to countertop push-ups, then floor push-ups, and then with bent knees on the floor if possible. And then also he'll walk, so he will ambulate 4 sets of 25 feet 3 times a week for the first 4 weeks, and then he'll progress to 4 sets of 50 feet 3 times a week, and then 75 feet and 100 feet as appropriate, with his cane as needed. Time with the physical therapist will initially be devoted to education, coaching of exercises, and soft tissue mobilization for motion restoration and pain control. Also, skill training, coordination training, and balance training will require therapist time initially until the patient is comfortable with the material. As the patient and caregiver feel comfortable transferring exercises from clinic to home, they'll be incorporated as possible and appropriate in the home exercise program. Recommended activities will be instructed and supervised at first by the physical therapist, and after they're learned, they can be supervised by the PT or PTA or tech in a clinic if appropriate, or the patient's wife or aide at home unless they require no assistance, as in bed mobility and bridges. It is also recommended that the patient participate in a group Parkinson's-based movement and therapy class for socialization, help with depression, increased compliance, and increased capacities. Environmental recommendation. The patient lives in an apartment with no stairs and already has grab bars in the bathroom, so he should be okay there. But he may benefit from modifications in his sleeping situation with some grab bars installed close to his bed to allow him to achieve more modified independent mobility more easily. In terms of adaptive equipment, the patient already owns, that was stated. He has a straight cane, tripod rollator, shower chair, commode, and 2 grab bars. He also has a motorized scooter that he uses when traveling farther than 4 blocks, so he seems that he has adequate equipment. If new equipment is needed, it will be ordered through a durable medical equipment supplier in consultation with the physical therapist to make sure the correct equipment is ordered. The patient will be trained in the use of such equipment by the physical therapist as needed in the clinic or home setting, as the case may be. And it will be decided if the equipment is effective based on if it is able to allow the patient to accomplish whatever hypothetical use it is meant for, such as ambulating a certain distance with a certain level of assistance. The patient will continue to be seen in outpatient, however, based on his prior hospitalization and inpatient, it's possible that he may need home health again at some point. Home health is another alternate setting. Since he's already received it, it's possible he could need it if, depending on the course of his illness, or if he falls and injures himself badly enough, requiring surgery, then he would need acute care again as well. Outpatient setting is optimal for now. It will allow the patient to have access to equipment he won't have at home. And cost of coverage hopefully will be taken care of by the patient's insurance. He is likely covered by Medicare based on his age. If he does not also have a Medicare supplemental plan, he may have a private plan as well. Components that could be carried out by the PTA or under the PT's supervision, of course, would be therapeutic exercises, soft tissue mobilization, training for balance, coordination, and gait speed. Those could all be performed by the PTA after the PT has established the plan of care and made this clear to the PTA. Home health aide or personal care attendant or a family member, also under the PT supervision, could help with home exercise program exercises that carry low risk. They could also provide help with transfers and in ambulation as needed. As far as what can be done independently, the same applies here. Most exercises, and including transfers and bed mobility and assistance in gait, could be supplied by, could be performed independently, as long as the patient has progressed to that level of independence, of course. Determination of whether the interventions are effective or not, and if they should be continued, modified, or discontinued. The interventions will be assessed using outcome measures that are tied to specific capacities that have been addressed by the plan of care. For example, range of motion through goniometry, strength through manual muscle testing or dynamometry, balance through the functional reach assessment, the tug and the Tonetti as was already performed, and coordination with the various coordination tests like fingers, nose, and toe tapping that were performed. Interventions will be continued if progress is being made or if important capacities are being maintained through the intervention, then they'll be maintained. If they need to be modified, that will happen because they appear to be ineffective, or if the patient reaches the goal that the intervention was designed for, and then they need to be progressed, they'll be modified. They'll be discontinued if they're deemed inappropriate or if the patient outgrows them. In terms of asking why I anticipate or what I anticipate will be needed when I discharge this patient, at discharge it's likely the patient will, it would be necessary for the patient to continue to receive care from the home health aide, and as the patient's wife is also dealing with a cardiac condition that limits her ability to assist, there's a good chance the patient will recover some of his functional capacity that was lost over the last month away from home. And so he may be less dependent across the board than he currently is. The patient will likely need to use the same assistive devices, but hopefully to a lesser degree than before. Perhaps he'll ambulate for a longer distance before needing to use the rollator walker, for instance. Knowledge that the patient's condition is progressive, though, and that he is of an advanced age and has had this diagnosis for 9 years, it will be necessary for great care to be taken in any activities that involve increased fall risk, especially given his history of frequent falls. And that wraps it up. Thank you.